In exam, they don't write cerebellar examination. They write to rule of posterior cranial fossa tumor. This terminology you have to know. Right. So if you have read and understood, considering the clinical examination station, can you begin?
Okay, I'll enter the room. I'll wash my hands. Then I'll introduce myself. Hello, I'm Dr. Karma, one of the exam candidates. May I confirm your name in it, please?
Yes, 49 years old, Smith.
Smith. Hello, hello, Smith. So today I've been asked to examine your nervous system and your reflexes, which will involve looking, feeling, and also moving your upper and lower limbs. Are you okay with this?
Yes.
Okay, so I need you to remove your gown and you can keep your vest and the shorts. I need you to expose your neck and shoulder and also upper limb and also lower limb below the knees. So Smith, can you stand to start with? Can you stand for me, please?
Yes.
And I'll do the Rhombus test where I'll ask him to keep his feet together and hang his arms by the side and then close his eyes. I'll reassure him that I'll not let him fall by keeping one arm in front and one arm behind and to support in case he falls, and then ask him to close his eyes and see the Rhombus sign. Okay, Smith. Now I hope you have no pain in your legs. Could you walk for me, please? Could you walk towards the wall for me, please?
Okay.
And I'll see his gait and his stance and any unsteadiness or any broad-based gait. Then Smith, when you come back, can you walk like this for me? I'll show him how to walk, heel to toe walk in a straight line.
Yes.
And see the tandem gait.
Yes.
Okay, Smith. Now you may sit. Now I'll need you to. I'll do the nystagmus test where I'll advise him to keep his head still and follow my fingers by his eyes and move in an H-shaped manner and look for any nystagmus. And then I'll ask test his speech. Smith, can you repeat the word British Constitution for me, or baby hippopotamus, and see if there's any scanning or slurring of speech. Then I'll examine the nerves, cranial nerves, associated cranial nerves, say for glossopharyngeal and vagus. I'll ask him to open his mouth and say "ah" for me. Smith, can you open your mouth and say "ah" for me? And then I'll ask him to cough. Then to test the accessory nerve, spinal accessory nerve, I'll test for trapezius and sternocleidomastoid. I'll ask Smith, can you shrug your shoulder against my hands? I'll put resistance, and also I'll ask him to turn his head on the on right and left against resistance to test the accessory nerve. Then I'll to see the hypoglossal nerve, I'll ask him to protrude his tongue.
Yes.
Smith, can you protrude, show me your tongue and see for any deviation. And also, Smith, can you push your tongue against your cheek to see the power and all?
Yes.
Nice. Now, Smith, I'll have to examine your arms. So can you keep your arms floppy or soft? And do you have any pain at the moment in your arms?
No.
Okay, so I'll see for tone. I'll move his wrist and his elbow, passive movement of the wrist and elbow to check his tone. Then Smith, I'll need you to do some movements. Can you do this one? I'll ask him to, I'll show him how to do the finger nose test. where he will point his index finger on the nose, and then from the side he'll bring to the nose on both the sides for a few times, and also finger nose test, where he will touch my finger and then his nose, and rapidly on both sides. Here I'll test any intentional tremor or pass pointing, and also I'll show him how to do this side of cokinesia. Okay, Smith, I'll need you to tap your hands on the other hand on palmar and dorsal aspect rapidly, so that to see for this side of cokinesia. And Smith, I'll need you to do some test. So I'll ask him to raise his hands straight in front of him with in supine position, the palm facing upwards, to see the pronator drift, and ask him to close his eyes and see whether there's any drifting of either arms. Then I'll test rebound phenomenon. Smith, can you close your eyes and then push and not let me push your arms down? Then I'll suddenly release and see for rebound phenomenon. Smith, now I need to check your reflexes, check for biceps, triceps, and supinator reflex. Now, Smith, I'll need you to lie down, and I'll have to examine your legs. I'll ask him to lie down. Smith, do you have any pain in your legs at the moment before I begin?
No, continue.
No. Okay, so I'll need you to keep your legs floppy. Then I'll do test the tone of the lower limb by leg roll and leg lift, and I'll ask him to do the heel shin test.
Okay,
and then
can you
the
present
reflexes.
your case now, please?
Yes, today I've to complete my examination.
Yes.
I would like to do full neurological examination,
yes,
including the cranial nerves and upper and lower limbs. And today I've examined
and the reflexes
Smith, 49
that you have
years
missed
old male.
of ankle and knee and the coordination. Okay. Yes. Continue, please.
Yes, I told quickly, ma'am, at the end.
Yes. Yes.
Yes. So today I've examined Mr. Smith, 49 years old male, with a history of posterior cranial fossa tumor. And on examination, I found that he has a broad-based gait, and he could not perform the tandem gait. And on examination, he had slurred staccato speech, and there was no nystagmus. The associated cranial nerve examination was normal. His upper limb examination showed incoordination, pass pointing, the positive disc cokinesia, positive pronator drift, and pronator drift.
So what are the differential diagnoses that you'll consider for this patient?
Considering this history, I'll first of all keep my provisional diagnosis as cerebral ataxia secondary to posterior fossa cranial tumor. I'll also need to consider cerebral mets and cerebrovascular stroke, transient ischemic attack, head injury, multiple
what
sclerosis.
What investigations would you ask for to confirm your diagnosis?
For the investigation, I'll do X-ray, which might show calcification. I'll also do contrast enhanced MRI or CT scan, and also to rule out the primary, I'll need to do CT scan of the whole body, and also CT image guided biopsy will be required.
Why not? You'll ask for the PET scan if you suspect there are bony metastasis to the skull of the brain.
Primary, yes, ma'am. Yes,
primary or the secondary?
PET scan.
Yes. Why would you not? When MRI for brain, enhanced MRI for brain is beneficial, in which conditions or cases?
MRI is beneficial usually in posterior fossa cranial tumor, ma'am, because the CT scan on is thick.
What are the common posterior cranial fossa tumors that you know of?
We have the glioblastoma, medulloblastoma, astrocytoma,
Yes.
hemangioblastoma, ependymoma, and also
Yes.
metastasis secondary tumors.
Okay, good. Bella is gone. So who would, Dr. Kolade, can you please give feedback first? Because you're going to appear in the exam, or Dr. Shoaib, who are appearing in the exam. Can you
Okay,
give the
ma.
feedback first?
Okay, ma. Thank you, Dr. Kama. I think he did most of the
Examination.
and things they're supposed to, yes, examination,
Yeah.
most of the things they're supposed to assess for. But since it's not a typical patient this thing, we may not be able to see how good some of them are. But I think
Yeah.
also for the other thing I just want to mention, for if you are checking for the eye to nose to finger parts, pass pointing, I think the patient, your hand should be patient should be able to stretch his hand very well, so that I think that one is very, very important as part of the. But otherwise, then the examination, the other thing I also mentioned, the exposure. I think patients
Does
to
not
me, I think
need.
patient doesn't need to
No.
expose,
Yes.
because the way
Yes.
you mentioned that patient needs to expose, I think it's not necessary
No.
that patient must
not.
be exposed
Good.
completely. So because for the hand, for the upper limb, just to examine the tone and the distance, if patient
Yes.
has rolled off his shirt or whatever he's wearing, one
Yes.
is able to do that. I think those
Yes.
are the things and
Okay,
then for
good.
the discussion part, I think it needs to check the other tumors. I think there are so many tumors, and then they mention S3, and then that can be also show the S3, called S3, that may show calcification as well. And then even CT, one can still do CT. So since they just said we should mention, so you can mention all the three: S3, CT, and MRI. If they now say which one will be better, then the MRI will definitely be better than the first two. All right, thank you, sir. Thank you, ma'am.
Thank you so much. Okay, it was very good, Dr. Karma. I think you're the first time presenting examination station, so I don't know if you have done it before. There was just one which Dr. Khalida pointed out, that there's no particular exposure needed except for the reflexes, and you know how much exposure one needs for the reflexes, not much. So that is the one thing. Secondly, when you were doing examination 6 minutes, it was very good. Even when you finished it, you did mention how to complete your examination, the things that you forgot. But one thing that you did, that when you were presenting your case, you said the patient came with the history of posterior cranial fossa tumor. No, but you have to say that a patient came and I did these examinations to rule out posterior cranial fossa tumor. And once you are saying it to rule out, then you have to tell all the clinical features which should be present in a patient with posterior cranial fossa tumor. So the most important was when you were doing the Rhombus test. So that should have been negative. Then you would tell that no, Rhombus test, Rhombus sign was negative. Speech, what type of speech that was, right? There was no nystagmus. Okay, no need to mention that. All right. And then there was cranial nerves were all normal, but then gait was broad based. The patient was not walking normally. Patient had a broad base, took very broad step. So that is something, and patient was unable to do tandem gait. So these are the positive things. And for upper limb posterior, pronator drift was also positive. Rebound phenomena was positive. There were tone when you were examining of upper limb. There was hypotonia. So these are the things that, and there was also this diadokinesia present. So these are the things, and also intentional tremors were present. I think you did not mention the intentional tremors in upper limb examination. So once you are presenting your case in 30 seconds, if you want to make your diagnosis, your primary or provisional diagnosis as posterior cranial tumor fossa, because this is what they write in the examination, and it was also given in the STEM in the question. So you had to mention all the clinical features that should be present in a patient with this type of tumor. This is just my little advice and request. All the rest were Dr. Palade has told you for
Okay.
examination and etc. So just this little message you can take. Thank you.